All right. So my name is Lauren Moore. I'm the Chief Scientific Officer of the National Ataxia Foundation, and I'm very excited today to introduce our speaker, Tara Newcomb, who's going to be speaking all about genetic testing and counseling. Tara is a board-certified genetic counselor who specializes in neurology genetics, including pediatric neurology. She completed her Master of Science in Genetic Counseling at the University of Utah in 2010. Prior to joining Geno Medical, which is where she is now as a counselor, she worked at the University of Utah in pediatric and adult neurology clinics, as well as in neuromuscular genetics research. We're very excited to be partnering with Geno Medical on our free genetic testing and counseling initiative for individuals at risk for SCA 1, 2, and 3. But I'm sure Tara is going to cover much more than just that program. So please join me in welcoming Tara Newcomb.
Thanks, Lauren. So I'm Tara. I am as Lauren said, a genetic counselor at Geno Medical. Let me share my slides so that we can go ahead and get started. So I have been working as a genetic counselor since 2010, primarily in neurology through the University of Utah, and now at Geno Medical. Currently I live in Nebraska, and so I, your family, enjoy spending time with my family as well as extended family here. But happy to be with you today and talk a little bit about ataxia, genetic testing, and genetic counseling, and provide some information on all of those things. So just briefly, Geno Medical, we are a digital health company. We provide genetics and genomics care through telehealth, both video and phone. We are kind of an independent medical practice and available for self-referrals as well as physician referrals, but and I'll get into a little bit more about kind of some of the things we do throughout the presentation. Just a short disclaimer, there is a lot of medical information that I'll be presenting today about genetic testing and genetic counseling. Basically, this is general information, and any medical decisions you make or you discuss with family members should be reviewed with your own medical providers. So this is not meant to be personal medical advice. So what we'll do today is I'll just give a brief background in genetics as well as inheritance. We'll talk a little bit about ataxia, but I'm not going to spend a lot of time on the different types of ataxias. And then we will talk about genetic testing, the different types of genetic testing, as well as genetic counseling, what that looks like, what it entails, and then have some time for questions. So first off, kind of genetics 101, which may be a review for some people. But basically our genetics, our DNA is the instruction manual for our body. So it tells our bodies how to grow, how to develop, provides basically everything we need to survive. Our DNA is organized into structures called chromosomes. Most people, we expect to have 46 chromosomes, 23 from our mother, 23 from our father. And then on each chromosome, DNA is organized into segments called genes. When we're talking about genetic disorders, we are often looking at a specific gene or group of genes to see if there is a problem with a certain type of instruction or a certain gene that may be causing a medical problem. So this picture just shows a little bit more where the chromosomes are located. So you see there chromosomes 1 through 22, and then X and Y. Females have 2 X's, males typically have an X and Y. These chromosomes are located in the nucleus. And when we talk about DNA or genomic information, usually the chromosomes are what we're referring to. In addition to our chromosomes, we also have DNA in small, what are called organelles that are mitochondria in each of our cells. And the job of the mitochondria is to create cellular energy, so energy that the cells need to do their job. Inside each mitochondria, there is actually another small piece of DNA, and mutations or changes in this DNA can also lead to genetic disease, some of which can have symptoms of ataxia. So while mitochondria is not often included when we're talking about basic genetics, I thought it was important to make sure we at least bring that up today because it can be relevant for genetic testing in ataxia. And so we'll come back to this in a little bit. So when we are looking at DNA and talking about DNA in inherited disorders, we're often looking for changes to DNA that might cause problems. And we can have different types of mutations, variants, genetic changes. Those are all words that may be used to describe a difference in your genetic material that could lead to a disease. Some of these are single letter changes. So if you think of each gene as a sentence or an instruction, you have what we expect to be there. The gray cat ran down a hall. And if you substitute the F for the R, now you have the gray cat fan down a hall, which doesn't make sense. And so leads to errors in how your body is interpreting those instructions. Sometimes when we have changes to our genetic material, we may have information that's missing. So a deletion, sometimes we have extra information, which would be a duplication. All of these things can potentially lead to disease. So when we're doing genetic testing, these are some of the things that we are looking for, are changes to what we expect that instruction or that sequence to say. In ataxias, there is another kind of group of disorders or changes that we spend a lot of time thinking and talking about, and these are repeat expansion disorders. This is where there's not a spelling error, and it's not necessarily a duplication of a whole gene or a region of a chromosome, but 3 letters within a gene can be repeated over and over again. And that can be typical. So if you think about the sentence analogy, you may want to get across a point that this is a really fat rat. So the cat ate the fat rat would be an example. And then repeat expansion would be too many of those 3 letters. So now you have too many fats and easily can get lost in that sentence and kind of forget where you are. The sentence becomes cumbersome and interrupts or affects how your body might be interpreting that instruction. So these triplet repeat expansion disorders are relevant in ataxia, and we do see a lot of them, probably more than any other kind of genetic area of focus or discipline. I would say we see more of these types of mutations when we're talking about inherited ataxias. So some additional special considerations when we're talking about repeat expansions. One thing that may be different about these compared to other types of mutations is the size of the repeat can sometimes correlate with age of onset or disease severity. Repeat expansion can get larger when passed from one generation to the next, which is called anticipation. And then the likelihood of anticipation happening or that repeat expansion growing can depend on if the expansion is inherited from mother or father. With the other types of mutations, a point mutation or a spelling error or a deletion or duplication, we can still see some correlation with severity depending on the familial mutations. So some mutations may be associated with more severe disease, while others are associated with milder disease. Sometimes in all genetic disorders, we may not necessarily see that correlation between disease severity and mutation. So sometimes it can be unpredictable. A lot of times when we're talking about genetic testing and genetic material, we'll use a book analogy. So a genome is really the whole thing, all of your genetic material, the genes from all 46 chromosomes, and typically including mitochondrial DNA as well. A chapter would be considered a chromosome, so kind of a section of your genetic material. And then a sentence would be a gene. We typically have 2 copies of every gene, as mentioned before. And so that's kind of what we're expecting when we're starting to do some genetic testing, and looking to see, okay, do we have a primary copy and that backup, or is something missing, or do we have too much information? And then genetic testing is often can be done on various tissues. So blood, saliva, sometimes tissue samples. Most of the time with the genetic testing that we're doing now is often on saliva or cheek swab samples. So another kind of important aspect of genetics and genetic testing is considering inheritance patterns. So not all genetic mutations or genetic conditions are inherited in the same way. Inheritance talks about how a condition or a trait is passed from one generation to the next. So we can use inheritance terminology when we're talking about things like genetic disease. You can also use inheritance when you're talking about things like hair color, eye color, whether or not your earlobes are attached to the side of your head, right? There's a lot of different things that are inherited, and they often follow these different types of inheritance patterns. The first 2 sets of patterns are autosomal dominant and autosomal recessive. These are the most common inheritance patterns. Autosomal just refers to that the gene is located on chromosome 1 through 22. So there's no difference in the set of whether you have 1 or 2 copies in male versus female. And then dominant and recessive refer to kind of how that trait is passed on. So a dominant condition or a dominant trait, you only need to have 1 mutation in order to have that trait show up. So oftentimes eye color is a common example. Brown eyes are dominant over blue. So if you have 1 gene for brown eyes, the brown eyes is present, regardless of what's on the other chromosome. Many ataxias can also be inherited in an autosomal dominant pattern. With autosomal dominant conditions, there's a 50% chance for the affected parent to pass on that trait to each child. That 50% starts over regardless of what your first child, whether they are affected or unaffected, kind of you start then a fresh 50% for the second child, and so on and so forth. So biology does not always follow statistics, and we can see that in some families, maybe all children are affected versus other families where none of the children end up being affected. Similarly to gender in families, where some families end up with all boys and others end up with all girls, while some have that 50-50 split. For autosomal dominant conditions, the status of the unaffected parent doesn't really contribute necessarily to the risk of having an affected child. Also, if you are an unaffected child of an affected parent, you can't pass that trait on any further. So if you don't inherit a trait or a genetic mutation from an affected parent, there's no risk for you to then somehow pass that on to your future children. There are cases where someone may have a genetic trait, but not necessarily display symptoms of a genetic disorder, which we can get into a little bit later. That's called reduced penetrance or variable expressivity. But in general, if we're doing genetic testing to see, does someone carry a mutation, and they are negative for a known family variant, that risk to then pass it on further is 0. Autosomal recessive conditions, these are conditions where we don't necessarily see them running in families, as in multiple generations tend to be affected, but we do see multiple siblings that can be affected and have 2 what we call carrier parents. So in these conditions, you need to have a mutation or carry the trait on both copies of your chromosome in order to have that trait present. So individuals with blue eyes, in order to have blue eyes, you have to have that trait on both the copy from your mother and from your father. So a carrier may not have any, a carrier typically does not have any symptoms, when we're talking about autosomal recessive disorders. And if they happen to have a reproductive partner who is a carrier for the same rare disease, there is a 25% chance with each pregnancy to have an affected child, a 50% chance to have a child who is a carrier like them, so no medical risk or risk for clinical symptoms, but that child would then have a reproductive risk depending on the status of their reproductive partner, or a 25% risk to have a child who is unaffected and not a carrier. That child would then not have a risk to pass on that same condition when they're ready to have children. Similarly, we do have X-linked inheritance patterns. So these are very similar to autosomal dominant and autosomal recessive, other than these are genes that are located on the X chromosome and therefore may have different implications for males versus females. As you may remember, females have two X's, males have an X and a Y. And so that can affect how things are expressed or what genes tend to show up versus be a carrier for. In X-linked dominant conditions, you only need to have that mutation on one X chromosome in order to have the disease. That may mean that men may be more severely affected than women. It just really depends on the specific condition. But in these cases, if you have an affected male of an X-linked disorder, it is 50%, or sorry, excuse me, all of the daughters would be affected, all of the sons would be unaffected just by that condition being linked to the X and Y. It's linked to the predicted gender as well. For mothers who have X-linked dominant disorders, it's very much the same as autosomal dominant disorder. There's a 50% chance to pass that condition on to both boys and girls. For X-linked recessive conditions, an affected male would have, again, all healthy sons because it's that Y chromosome does not carry the mutation, and all daughters who are carriers. So in X-linked recessive, we typically see affected men or affected males and unaffected females. For females who are carriers of X-linked recessive conditions, we have a 50% chance to have an affected son and a 50% chance to have a daughter who's a carrier. And then last but not least is mitochondrial inheritance. So as I mentioned previously, sometimes we can have changes or mutations, spelling errors in that small amount of mitochondrial DNA. The interesting thing about mitochondrial DNA, all of our mitochondria come from the egg. So at conception, you have the egg and the sperm. The sperm is just the DNA on the chromosomes. Within the egg, there are also mitochondria that then become the mitochondria in that child's, all of that child's cells. So for mitochondrial diseases, if a mother is affected, all of her children will have, are predicted to have affected mitochondrial DNA. There can be variability in how much of the DNA is affected. And that would be kind of a one-on-one discussion probably with a provider. I'm happy to answer questions about it at the end, but it gets into a little bit of specific disorder questions. If the father is affected with a mitochondrial disorder, we expect that none of his children would be affected as they would receive all of their mitochondria and therefore mitochondrial DNA from their mother. So enough genetics for now. We will talk a little bit about ataxia, and then we will quickly come back to the genetics information. So I probably don't need to spend a lot of time on this with this group, but ataxia just means without coordination or uncoordinated, basically. It's a nervous system disorder, often affects the cerebellum, the portion of your brain that controls movement, and it is often progressive. So the symptoms get worse over time and may affect more and more body systems. Common symptoms initially include balance problems, changes with speech or dysarthria, swallowing difficulties, changes in eye movements or eye movement coordination problems. Hand coordination can be affected. And then every different type of ataxia, right, may have other symptoms that can be present. Cardiac involvement, neuropathy, other neurologic movement problems such as tremors, dystonia, spasticity. We can see hearing loss, we can see seizures. We can see developmental problems, we can see cognitive decline and dementia. It really can be pretty broad, depending on pinpointing that underlying cause, what other symptoms may show up. And it's also very variable age of onset, right? We have some ataxias that can be onset in early childhood, while others may not present until much later into adulthood. There are many different causes of ataxia. We will spend most of our time on the inherited forms just because that is my background. You can also have acquired or environmental forms of ataxia and multifactorial forms. To talk briefly about environmental or acquired, these are things that are typically caused by an exposure or something in the environment, something that happened, not an inherited, not something caused by your genetics. Oftentimes we don't have a family history of ataxia for individuals who present with these forms of ataxia, include vitamin deficiencies. Autoimmune conditions, at this time, autoimmune conditions are still largely considered multifactorial or environmental. There is some changing in that landscape with genetic testing for autoimmune conditions as well, but we won't get into that. Multiple system atrophy, which can present with ataxia and Parkinson's-like symptoms. Exposures to toxins may cause ataxia. And then we have multifactorial ataxias. And this is kind of like a catch-all, like we probably don't necessarily know maybe what caused your ataxias, or we have a family history, but it's not a clear pattern where we see, one generation for the next where we can kind of trace it back. But there's more ataxia in an individual's family history than we would expect. Most of the time with a multifactorial condition, we're not necessarily able to pinpoint a specific environmental cause, and our current genetic testing is not set up. We don't have the information to be able to do genetic testing for multifactorial ataxias. So these types can be kind of hard to provide information on recurrence risk, or kind of sometimes it just is nice to be able to identify a cause and to know why something happened. And with multifactorial disease in general, and that can be really challenging to do. Inherited ataxias. So we say this as like one group, but really inherited ataxias can encompass many different conditions. They are joined by being caused by a mutation or problem in a single gene. So when we're talking about inherited ataxias, at least when I'm talking about them, I'm talking about those that have a single gene cause where one mutation results in either a definite chance to develop that disease or a very high chance to develop that particular condition. And these can include spinocerebellar ataxias, episodic ataxias, Friedreich's, ataxia telangiectasia, mitochondrial disorders with ataxia. And then there are many, many genes that are associated with either ataxia as the primary feature or other inherited conditions that can have ataxia as part of that presentation. So some of the panels that are available for ataxia, if you expand it broad enough, can approach 1,000 genes. So there's a lot of different genetic causes here that we have to kind of not necessarily sift through, but it's a broad category. So when you have that much information and that many types of that many conditions that can kind of all have this shared feature, genetic testing can become important and can be a great tool to try and understand, okay, what is going on here? Genetic testing isn't the only tool. So a good clinical exam by a neurologist, imaging, those are all still important tools to be able to say, okay, here's the category you fit into. Genetic testing is another tool in that toolbox to be able to try and pinpoint a specific condition or a specific group of conditions that might fit best. With genetic testing, there are many different types of genetic tests, and it's important that we ensure that the right test is done to be able to give you the right information. If we don't do the right test, then that's not very powerful, and it doesn't provide the best resource moving forward to make sure we're getting the right types of medical management, providing the right information to family members. So working with your provider to ensure that the right test is done is kind of step number one. And we'll kind of go through the different types of genetic testing that we do on a regular basis. So the simplest one is targeted or family variant testing. This is done if there is a known family history. So if you have a relative who has ataxia or has had testing and they have a known mutation or a known repeat expansion in a specific gene, then family members can have targeted testing to see, okay, my mother has SCA1, she has a repeat expansion in ataxin1. I want to get tested to see if I inherited that repeat expansion or if I inherited the normal copy. So targeted variant testing is very straightforward and leaves less room for some of those more ambiguous results that we can see with broader testing. Single gene testing is very similar. This is probably done maybe if there are clinical features of a specific disorder where there's not necessarily a known family history, but a clinician may have a strong suspicion that an individual has a specific single gene cause for their ataxia. Single gene testing can kind of overlap into repeat expansion testing. So repeat expansion is looking at those specific ataxias that are caused by those 3 letters that are repeated too many times over and over again. Repeat expansion testing is a little bit tricky just because it often cannot be done with the next type of testing that we'll talk about, which is a panel test where we're looking for spelling errors in a lot of genes. So often labs will offer single gene repeat expansion tests where you have to kind of pick the one you think is most likely. If that's negative, you would go to the next one. Or there can be small panels of repeat expansions where they'll look at, 6 to 10 of these repeat expansion genes at one time and give you multiple results at once. And that would be if you have symptoms of ataxia but a lot of these, it's hard to necessarily tell specifically what type you may have based on clinical features alone, which is why genetic testing can be such a great tool. But we may not be able to, it makes more sense sometimes to be able to do multiple genes at one time and can be more cost effective to look at these genes all together rather than doing the stepwise, which can add up quickly if you're not right the first time or two, as well as that timeline just takes a long time if you're waiting 3 weeks for the first test and then 3 weeks for the second test and 3 weeks for the third test. So being able to offer those all at once can be very helpful. The next type of testing is panel testing. So panels are often ordered for affected individuals, and they include many different genes associated with various types of ataxias. Panels are typically looking at genes that are not necessarily repeat expansions. So these are genes where we are reading that sentence, reading that instruction, and looking for a single letter spelling error. With genetics technology, we are now able to combine many, many different genes and kind of have them read through all at once to look for these types of spelling errors. Panels can range from looking at a few genes at once for a targeted clinical picture to expanded ataxia testing, as I mentioned, where we're looking at nearly 1,000 genes at one time. Many panels do not include repeat expansion testing, so you have to order if you have a clinical presentation or clinical symptoms of ataxia and you're trying to do genetic testing, you may need to do this panel test looking for spelling errors. And then in addition to, if test number 1 is negative, repeat expansion testing or vice versa. So just something to be aware of when pursuing genetic testing. The last option that we will sometimes do is exome sequencing. So exome sequencing evaluates all of your genes in the exome. So when we're talking about those genes, every gene is like that sentence that I said. Exome is really just looking at the sentence, the final product that becomes a protein and that is kind of doing the work in the body. In reality, when we're looking at those sentences, there can be genetic information or DNA interspersed in between some of those words, that is important in regulating what sequence goes out to do the work in the body. Exome is, like I said, just looking at that final product. It makes up about 1 to 2% of our genetic material, but contains the majority of known inherited genetic mutations. Genome sequencing does evaluate all of the genes, including more of that sequence that does not provide instructions, so that in-between genetic sequence. We're in the early years of genome sequencing, so I think there are still some, sometimes we don't necessarily know how to interpret all of that genetic material or genetic information and know what might cause disease versus what does cause disease. But that's kind of the difference between exome and genome. So exome is looking at sequence that has been really well analyzed and we feel like we understand pretty well. Genome includes some additional sequencing, which we feel like is important, but we're still learning about. Regardless, exome and genome is taking a really broad look. So if panel testing, if you go back to that book analogy, panel testing, we're picking which chapters we want to read first, and then we're reading them to look for spelling errors. Exome and genome, we're just starting at the front of the book, we're reading it all the way through, and then any variants or spelling errors that are picked up are assessed, analyzed, and filtered to see if they make sense for your personal clinical presentation. So there is some analysis that goes in based on kind of symptoms reported. It's certainly not a perfect science, but it's been improving, and I think we've come a long way in our ability to use exome sequencing data. Repeat expansion disorders, again, are not detectable by exome sequencing. That is one of the limitations of just how the sequencing is done. They may be detectable and reported in genome sequencing. So it depends a little bit on which lab. Not all labs have the ability to detect all repeat expansion disorders. But again, depending on your unique situation, that can be a discussion and just making sure that we're looking into what's relevant to your personal and family history. Overall, when we're looking at genetic test results, there are kind of 3 bins that we put types of results in: positive, negative, and uncertain. A positive result is often pretty straightforward. It's a genetic variant associated with a disease. And then you can kind of go into details on that specific gene, that specific condition, the variant, what we know about it, and really delve in from there. A negative result, and I guess positive, other words that you may see for positive include pathogenic or likely pathogenic variants. These are terms that we use in genetics to classify genetic variants and how likely we think they are to cause a disease. Negative or benign or likely benign results. These are no genetic variants were identified in the gene or genes tested. There can be limitations with negative results, which we'll get to here in a minute, but it means we didn't find anything on this specific test to explain someone's symptoms, or in the case of family variant testing, you did not inherit that particular family variant. Uncertain or indeterminate. These results can be challenging. These results can also be common, especially if we're doing a very large panel or an exome sequence. These are variants where it's different or not what we expect to find in a specific gene. So there is a spelling difference, but we don't have enough information to know, does this actually cause a problem, or is this just part of normal human variation? Every human being has unique DNA, and so we do need to account for that when we're doing genetic testing. The majority of uncertain variants get reclassified to benign or negative in their interpretation. They are something that we often follow over time. And depending on the laboratory where the testing is done, that follow-up could be automatic by the lab, where you get updates on an occasional basis, or if there is an update to be had. Or it may be something where you or a provider needs to be more proactive about looking into that particular variant as time goes on. Uncertain variants are often considered for these sequencing. so spelling error type mutations. In repeat expansion disorders, there's not necessarily uncertain variants. We have a specific number of repeats that's typically identified, but those ranges can provide some uncertainty as to, do people with this in-between number between normal and a repeat number where we know to cause disease, do people develop symptoms? Are they not at risk to develop symptoms? So sometimes there can be some indetermination there. Many times when we have these kind of in-between repeat expansions, there can be some instability and risk for that expansion getting bigger in future generations. But again, it depends a lot on the specific gene, what the gene number is. Is there a family history? Are there symptoms in this individual? So there's a lot that kind of goes into that interpretation of an indeterminate result that is hard to kind of put out a blanket statement on. This is how we deal with all indeterminate results. It really becomes more of a personal discussion. So why do people pursue genetic testing, or what are the goals or the benefits that we can get from genetic testing? There can be medical management implications. So being able to have proactive screening for associated signs and symptoms. As we discussed, there's kind of that long list of possible symptoms that can be seen in different forms of inherited ataxia. And so understanding if you're at risk for some of those may prompt additional referrals to a cardiologist or to an ENT or audiologist for regular screenings for those complications, as well as just understanding an expected course. So while at this time, there's no proven way to stop the progression of most of these inherited ataxias, sometimes people just want to know kind of what to expect, or how does this look in other individuals, and having that knowledge can feel very powerful for some people. Definitely doesn't have to be all people, right? Genetic testing can be a very personal choice, and so some people may not be as comfortable knowing kind of what to expect. And as with most things, genetic testing is not a crystal ball. We can't specifically predict the future with this genetic testing information, but it does give us a guide or kind of some knowledge for how things might look moving forward. Sometimes genetic testing can help with access to services or resources. So confirmation of a genetic diagnosis may be the documentation that someone needs for things like disability, or needs to have accommodations at work or at school. While we would like to think that that could be done even based on symptoms alone, sometimes having a label or a name to something can provide that background information for the people saying, oh, you have this condition and we know that XYZ is associated, or we know that we expect this to get worse. So let's stay on top of it or get ahead of it and be able to work together to provide the resources needed. Improving access to different medical providers or therapies, getting devices that might be needed, having that diagnosis confirmed can sometimes help with access to those things as well. Clinical trial readiness is a big topic in a lot of rare disease space, including ataxia. So there are many new treatments, trials, therapies that are, getting ready for approvals. And many of these treatments are targeted to a specific gene or gene. Genetic testing is important then to have that confirmatory diagnosis, because we want to make sure that if you're going to get an invasive or really expensive treatment, that we are treating the right thing, right? These treatments are targeted, so we need to make sure that it's going to be helpful for you and not ineffective. So genetic confirmation is often required for many clinical trials as part of the inclusion criteria. And while some clinical trials will do genetic testing as part of that kind of, let's see if you qualify for our trial, many of these clinical trials can be competitive and hard to get into, and a candidate who already has genetic testing in place may be able to move into that open spot faster than someone who still needs genetic confirmation. So it can reduce that time to enrollment and access to trials. And same with like if we had to have an FDA approved medication, Individuals who already have genetic testing on file are going to likely find it easier, just one less hoop to jump through to have access to that treatment or medication, compared to someone who may still need to obtain the testing and wait for those results. Genetic testing has improved as far as timeliness. So while we are able to typically get results in a few weeks compared to waiting months and months, sometimes that, the time to get an appointment, get the testing done, and have results can feel like a long time if you're waiting to start therapy. And then finally, a last benefit, which I don't want to overlook, is information for family members. So family planning, access to predictive testing. So genetic testing, while we are often focused on our patient in front of us, is really a family practice, right? So the results that you may get as an individual impact other members of your family as well. And if you have genetic confirmation, that provides an opportunity or information needed for any relatives who may want that information. Just because the information is available doesn't mean that they have to act on that, right? Not everyone wants to get predictive genetic testing, and they may not choose to get predictive genetic testing, and that is a very individual choice. But that opportunity is at least there for those who may want it. And if even in the setting of if it's not predictive testing, so a relative may choose not to have predictive testing, time may go on and they may develop symptoms of ataxia, and having a family member with a confirmed diagnosis can certainly shorten that timeline to getting a confirmed diagnosis for them, rather than, as many people probably have experienced, sometimes getting an answer can take a long time. There can be a lot of testing, a lot of back and forth, and so can shorten that timeline for family members who do develop symptoms. Another opportunity that comes along with having genetic confirmation is the possibility of things like in vitro fertilization with pre-implantation genetic diagnosis. This is not an option for all individuals, even if you do have a genetic confirmation. This is a process that there's a lot of moving parts, and so again, each individual circumstance is going to be different. So I can't say everyone definitely can get IVF and PGD. Which IVF and PGD is a process where eggs and sperm are retrieved, an embryo is created in a lab. That embryo is grown to a certain stage, usually 3 to 5 days, and then cells from that embryo, which are cells that go on to become placenta, not necessarily the baby itself, are tested and screened for a genetic condition. Step number one of being able to go through this process is to have a genetic confirmation. Step number two is to meet with a reproductive counselor or a lab counselor to see, okay, do we have all of the information we need, the right family member information to be able to really construct a more complex test to test this embryo. Embryo testing is more complicated than just testing an individual's blood or saliva. So there's a lot more that goes into that, but it becomes an option if we have the right information at hand. In that process, then individuals can elect to only transfer embryos back that do not have the inherited variant or the inherited cause for ataxia. IVF and PGD is not always successful, and like I said, there are certainly limitations. It is certainly not a process for everyone. There are other options for family planning for individuals who have genetic conditions, including egg or sperm donor, adoption, rolling the dice and just seeing what happens, right? But this is one that many people tend to be interested in. And so I just wanted to make sure and at least bring that up today. On the flip side, so we know I am a proponent of genetic testing. There are lots of great benefits for genetic testing. There are also risks and there are limitations to our ability to do genetic testing. So if we do genetic testing and we have a positive result, Sometimes that result may be unanticipated or provide some unexpected information on severity of disease, or in a predictive testing case where it's a family member, and you just weren't expecting to be positive, right? That can really be emotionally challenging. And we are aware of that and know that not everyone may want that information. And knowing that you don't want that type of information going into it is an important um, discussion point, right? That we want to make sure we're able to address. Sometimes we may have limited information. So we may do genetic testing and we may find a positive result, but it could be that it's in a gene where there are 3 other cases that have been reported. And so in that case, there might not be a lot we're able to offer as far as changes to medical management or knowing what to expect as an individual continues with this condition. So sometimes we're not able to be as thorough as we are with genetic conditions where we have a lot of information. Lastly, genetic variability. So there can be a lot of differences, even within the same family, within the same genetic condition, of severity, age of onset, additional symptoms. And so, as I said before, a positive genetic test result is not a crystal ball, and we provide as much information as we can, but the human body is complex, and so it can be difficult to be completely certain. In the event of a negative result, if we're testing an affected individual, we're often unable to completely eliminate the possibility of an inherited ataxia just because we don't know what we don't know. There could be other genes out there that could cause ataxia. And if we don't know about those genes, we can't test you for those genes. So sometimes that can be a little bit dissatisfying to say, well, we tested you and you're negative. You still have these symptoms of ataxia. It's possible it could be sporadic, but it's also possible that it may still be inherited. And in an unaffected case, if we don't have a positive relative to compare to, these are often considered uninformative negatives because, again, we don't know if your relative had a type of ataxia that we would have been able to detect, or if it's one of those where if they would have had testing and been negative, then we're unable to rule out that you may still be at risk. So sometimes we do have those cases. And then another risk that many people are concerned about, especially in the predictive testing space, are the risks for genetic discrimination. So we do have some ability to provide protection from this, and that falls under legislation called GINA, the Genetic Information Non-Discrimination Act. It provides protection for health insurance, employment, and housing. It does not provide protection for life insurance, long-term care, long-term disability. These are things where if you have a life insurance policy in place prior to having genetic testing, it would not change your current policy. But in applying for a new policy, if you have genetic testing on record, it may influence what you may have access to or the rates that you're provided for your life insurance. And these are all things that could be your specific scenario and discussion, could certainly be discussed in a counseling visit or a visit with a provider or a social worker who's familiar with GINA. So I know I'm running short on time. Briefly, genetic counselors. So who are we? We are advanced trained medical professionals. We have a master's degree specifically looking at human genetics and counseling and kind of how to help people through the process of genetic testing. So we are able to kind of take into context your personal and family histories, your experience with a specific disease, and our goal is really to help you make the best medical decisions for you. So whether that be moving forward with testing or deciding not to do testing, getting access to the important medical care or providers that you need, that is our goal with a genetic counseling session. We also hopefully are able to help explain complex genetic concepts or test results in a way that you feel like you can understand and own and kind of take ownership of that to move forward with your own genetic information, because it can be complex. and hard to understand, especially if you're looking at a lab report with a bunch of what look like foreign words on the paper. So in a genetic counseling appointment, it really is just a process of understanding to and adapting to your medical family information and implications of a genetic condition. So it's an active process, it's a discussion. Genetic counseling can be done for both usually rare conditions is kind of where we're at right now, although we do see some common conditions. Ataxia falls into that rare condition category. And our goal is to empower you to make decisions related to these personal and family medical histories. Genetic counseling can and often is independent of genetic testing. So just because you elect to have genetic counseling does not mean that we will force you to have a test at the end of the visit. It does not require that you have genetic testing. It's just a discussion so that you can feel informed, educated, empowered about the genetic testing process and move forward in the direction that's right for you. What does a genetic counseling appointment look like? So we have kind of two main categories of appointments, pre-test, and then if you do choose to move forward, a post-test appointment. Before an appointment, we often ask, and this is with Genome Medical or with another provider, we ask individuals to gather records. That could be, neurology notes, imaging. Genetic test results are really helpful if you have them from a family member, just to make sure that we are, again, doing the right testing. So back to that initial slide with all those testing options, having the most information up front can make sure that you get the right genetic test. During the appointment, these appointments can last anywhere from 30 minutes or less to sometimes 2 hours. Oftentimes, they're not that long, but if it's part of like a multidisciplinary clinic with a neurologist, certainly could be 2 hours or 2 hours plus. We discuss what your goals are, kind of what you want to get out of a session, review those personal medical histories and family histories, kind of go through, okay, here's what we think based on your symptoms. Here are the testing options. So kind of everything that we've reviewed today, but on an individualized level rather than this broad general scope. Would also talk about things like risks and benefits for you personally, your family members, discrimination possibilities, and kind of walk through that, as well as make a plan for results discussion. After the appointment, you would receive a summary of the note, and then if testing was desired, we would coordinate having that sample sent to you, or sample collection kit sent to you. For those who don't receive testing, then that would be the end. You would receive this note and you could always come back to us in the future with additional questions or concerns. For post-test counseling, you'd complete your testing with the laboratory. You'd be notified that results are back, and we do recommend having a support person available, especially for those going through predictive testing, just to have another set of ears listening for the information, although we do, again, provide things in writing, and just to have someone else to kind of be there with you, right, as you're hearing this information. Again, post-test appointments can range in length, discussing your goals, reviewing the positive or negative results. What does this mean for your medical management? What kind of providers do we need to make sure you have on your team? What do we know about this condition? What's the inheritance of this condition? How does this affect your family members? How can we help you identify support resources that you might need based on these results? And then again, receiving a note, kind of going through all of this information, recommendations, helping you contact providers, research studies, support groups, right? Even though we might just be a small blip in time of your journey, we want to make sure that you're supported and connected in the way that you need to be. So how do you access genetic counseling? So the National Ataxia Foundation currently has a program for no-cost genetic counseling and testing for those who have a family history of spinocerebellar ataxia type 1, 2, or 3 through Genome Medical. So you're able to go to the NAF website, follow the link, and schedule an appointment with one of our counselors who has experience in neurology and ataxia. Then we would go through that pre-test appointment, and you could elect whether you'd like to continue and move forward with testing, or decide not to move forward with testing at that time. At Genome Medical, we also provide genetic counseling for all inherited ataxias, as well as many other conditions. We work with insurance payers. We also have self-pay programs. This can be a self-referral, or we also do referrals from providers as well. Local neurology clinics are more and more often having genetic counselors in clinic or in the hospital. So if you have a neurologist, they may have someone that they would refer you to. And then there's also the National Society of Genetic Counselors, who they're an organization of GCs. We have a directory of genetic counselors that you can go and search for your area. You can often filter on specialty, so neurology versus if you have a genetic result and you really just want to talk about family planning, you could talk about with a prenatal genetic counselor. So that's a great resource as well. And I apologize that I did not leave much time for questions, but I'm happy to stay and take any questions.
Well, fantastic presentation, Tara, and thank you so much. There's a lot of useful information in there. So one question that a lot of folks have is genetic testing expensive? Can you give just an idea of what the out-of-pocket costs are for different types of genetic testing?
Yeah, that's a great question. So it does range. Genetic testing starts probably around $250, and that would be for a single gene repeat expansion test, or a panel of genes looking at spelling errors, so those non-repeat expansion ataxias, up to 1,000 to 2,500 for an exome sequencing, and then panels in between, probably 500-ish for like a repeat. I'm trying to remember the exact out-of-pocket cost, but I want to say it's between 500 and 1,000 for a repeat expansion panel. So it does range, but starting at $250 for out-of-pocket testing. Many labs do work with most insurance types, and there are often patient assistance programs as well.
Great, thank you. There's also a few questions about the limitations on getting pediatric patients genetic testing. Can you talk about when that's allowed and when it's prevented in pediatric patients?
Yeah, so in the past, there were a lot of probably more hard and fast rules about we won't test a minor for an adult onset condition. That's still generally the case. So for things like spinocerebellar ataxias, where we don't expect symptoms to start until adulthood, we tend to like to wait until a child is older so that they can be part of that conversation, and if they want that information. It used to be kind of 18 was kind of you're an adult now, you can have this testing. I think you'll find some counselors are a little bit more fluid of, okay, this is a very mature teenager and they really want this information, would have that conversation. Other times where we would do testing in a minor is if they're having symptoms of ataxia. So while we think most of the time some of these are adult onset, we know that there can be variability. So if there's symptoms in childhood, then of course, yes, let's have a neurologist evaluate them, and we can do some genetic testing. And then a lot of it is just kind of, when do we expect symptoms to appear? How old is the child? What do they understand about this information and process? Just to make sure that we're not doing harm and we're benefiting both a parent who may be concerned and worried, and a child who should have probably some say in these medical decisions.
Having a lot of folks ask about, how do I start this process? How can I find a genetic counselor, book an appointment? Do I need a referral? Can you just talk about the process of getting a genetic counseling appointment?
Yeah, so I can talk some specifically about Genome Medical. So for Genome Medical, we don't require a referral. You can go to our website and you can book an appointment, and we try and make it pretty easy. If you have questions, we do have coordinators who are available via phone, or we have a chat box on our website. You can chat in a question. For more of an in-person experience, starting with, if you have a neurologist, sometimes they may have people they refer you to. If you have a primary care provider, you can ask for a referral there, or that NSGC directory. So if you go to NSGC website, there's a Find a Genetic Counselor feature, and that will have then links to local clinics near you. If that particular counselor clinic doesn't see that indication, usually they will be able to direct you to a person or group who would be able to help you. There are also other kind of telehealth online opportunities for genetic counseling outside of Genome Medical. I personally don't know what their process and requirements are, but we don't require any sort of physician referral. We see patients self-referred all the time.
And if I can keep you here for just a couple more minutes, we'll try to fit a few more questions in. So if someone had a genetic test performed maybe 5-10 years ago, and there was no genetic mutation or variant found, is there a reason to go back and have repeat testing or more intensive testing?
Yeah, that's a great question. And possibly it would depend a little bit on what was included in that testing 5 or 10 years ago. Genetics has certainly grown and changed a lot in the past 5 to 10 years, both in number of genes available for testing. Tests that used to cost $10,000 are now a couple $100. So, I mean, I think at least having that conversation would be worthwhile. And it may be that with your particular symptoms, we say, you know what, no, there's not really anything that we would do differently, but more likely it would be, oh yes, we have this many new genes that have been identified, and we think that this testing could be important or helpful.
Great. And then finally, there's a lot of people who want to learn more either from you or from someone else. Do you have some contact information or link you can share where people can go and ask questions and get more information?
Yeah, so you can always, I am happy to share my email, and maybe I can have one of you kind of send that out for questions. We also have a website. Genome Medical's website has kind of frequently asked questions for more general genetic counseling concerns. But I'm happy to field questions. We also have a clinical team that you can call in, and I can make that information available after the webinar today.
Wonderful. Thank you so much. So I think we're going to stop it there, but I wanted to remind everyone that this video will be made available within about a week on NAF's YouTube channel and at the National Ataxia Foundation website. And we'll add Tara's contact information and some Genome Medical resources there that she mentioned. So apologies to anyone who I didn't quite get to your questions, but thanks again, Tara, for your wonderful presentation.
Yeah, thank you for having me.